Okay, I can see that, a couple of people are joining now. So maybe we can wait a bit more. Hi, and welcome everyone who is joining us today. It takes a couple of minutes until all the participants can join, and then we will begin our session. Full. Okay. I don't see any participants counting on. So, hi and welcome everyone. Good afternoon. I'm Zsófia from EFIC, European Pain Federation, and I'm really glad to be with you today. And we have three wonderful guest speakers here today with us, who will introduce themselves in a bit. We also have a Q&A part, so you can ask questions. Feel free to write the questions. We can leave, or we are going to leave a couple of minutes in the end of the webinar to answer a couple of questions. So it will be a great option to share some thoughts in the end. So today's webinar is co-organized by EACLIPT and the European Pain Federation EFIC, and navigating pain and mental health is our topic. Let me introduce EFIC a little bit. EFIC is a multidisciplinary professional organization, and we are in the field of pain research and medicine. We made up about 39 European chapters of the IESP, and we are a multidisciplinary institution, so we have close to 20,000 physicians, basic researchers, nurses, physiotherapists, and psychologists or other healthcare professionals across Europe. And we are going to have our next Congress in 2025 in Lyon, France. We will have really great plenary speakers and program. It will take place in France in April, and our topic is comorbidity of chronic pain and mental health disorders, so it's really a connection to our webinar today. So hopefully you won't miss any deadlines. We have an early bird registration until tomorrow, so actually we are really in time with that, and we will have a late breaking abstract submission until the end of November. So welcome everyone to join to the Congress in Lyon, and hopefully we are going to meet personally as well. So today we have three speakers, and I will let you to introduce yourselves. Maybe Winfried, you could start.
Yes, thank you, Sophia. So my name is Winfried Brief. I'm clinical psychologist in Marburg, Germany, and you might learn a little bit more when I present EACLIPT later.
Okay, thank you. Katarina, I see you next. So, oh, your mic is off.
I'm sorry about that.
No, that's fine.
So my name is Katarina. I'm also a clinical psychologist. I work as a senior researcher at the University of Fribourg in Switzerland, and also as a pain psychotherapist at the University Hospital in Zurich.
Thank you, Katarina. And Patrice?
Yeah.
Are you still there? Okay.
Super. Yeah. Good to be with you today. My name is Patrice Forget. I'm a professor of anesthesia and pain medicine in Aberdeen in the UK, and I'm board member of EFIC. And in particular, I'm the chair of the advocacy committee and the chair of the social impact of pain platform that you'll all discover later.
Thank you so much. So we are going to start. I will stop sharing, and Winfried, I give you the chance to share your screen.
Sorry, I had to turn my mic on, and this was impossible when presenting the slides. So let me restart again.
Okay.
You should be able to see my slides now.
Yes, yes.
Okay.
Yes,
So,
we can hear and see you.
Yeah, great. So it's my great pleasure to present some ideas here and to present also EACLIPT, a very young society that was founded just 7 years ago. And before I start to talk about EACLIPT, I would like to make the link to EFIC, because I think even me at a person, I was someone who tried to link the clinical psychology field with the pain field. And it was actually an EFIC meeting in 2012 where we decided to work on a new chronic pain classification, and I was member of that task force that finally came up with a presentation on and a proposal for chronic pain classification that was adopted for ICD-11 and will come into action in most countries of this world. But why did I mention that? Because when we had these discussions with the World Health Organization, WHO, it became obvious that we didn't have a clinical psychology society included, because many of these international societies are closely linked to one therapy tradition, like psychodynamic or CBT. And for this kind of purposes, you need a kind of neutral society. So we saw the need for a European or international academic society of clinical psychology. And this motivated me personally to be active for such a society, and others had other motives. So in 2017, EACLIPT was founded in Amsterdam. And meanwhile, we have more than 800 members from all over the field and in most countries of Europe and also outside of Europe. So the idea is to strengthen the academic input of clinical psychology, of mental health research and mental health care. But we also have webinars ourselves. So just to mention that if you are interested in this field, you can find many hours of video material on our homepage in the EACLIPT media section. You see a photo here, a screenshot with one of the first webinars with psychotherapy researchers like Paul Tsaikovskis or Bruce Wampold and Stefan Hoffman and others. So our next webinar will be in January 28 with the editor-in-chief of Lancet Psychiatry on the scenes behind the Lancet Psychiatry and how it is to publish in such a high-quality journal. So if you are interested, you are very welcome to join this webinar. We also launched a journal and the clinical psychology in Europe. And there's one unique thing about this journal I didn't mention on this slide, but the unique thing is we don't charge any article processing fees. So we are full open access, but thanks to supporting organization, we can manage to publish scientific papers without charging article processing fees. And you see that many of these papers are opened or downloaded more than 10,000 times. So we are happy that now, just in our 6th year, we became we received some popularity, and we are indexed in PubMed, Web of Science, and many others. So all of you who are interested to publish are welcome to submit manuscripts to this journal. And we also do congresses, and if you attend the EFIC Congress in Lyon next May, you might want to do some holidays afterwards. But 4 weeks later, you can come to Frankfurt and join the EACLIPT conference with very well-known keynote speakers. And 3 of them also will present workshops to get a hands-on training like Steve Hayes on ACT or Catherine Eubanks and on ruptures and repairs in therapeutic relationships. So you are very welcome to join these meetings. But let me make the link now to the topic of today, pain and mental disorders, or in particular pain and depression. Why is it so important to talk about both? Because we know that one is a risk factor for the other. If you have pain conditions, you are at increased risk of developing depression and vice versa. But we also know that pain and depression share common psychosocial and neurobiological mechanisms. Katharina will talk about neurobiological mechanisms a little bit later, but we also know about common psychosocial mechanisms such as emotion regulation or avoidance behavior, fear of pain, and these concepts are linking the mental health field with the chronic pain field. Although I want to emphasize, I think these are still different clinical conditions and they justify different classification, but they share common mechanisms. We also know that if people suffer from both, if they have comorbid pain and depressive conditions, then treatment can be worse than the treatment of one of the two. And many treatments show similarities between pain and depression, both psychological treatments, but also antidepressants. We also know that if people have still residual pain after treatments, this is a relapse risk factor for depression. And the treatment costs are really increased if people suffer from both conditions compared to either pain or affective disorders. So these are a few comments and that make the link to between chronic pain and mental disorders in general, and therefore I'm happy to hand over now to Katharina, who will present more specific results. Thank you so far.
Thank you very much, Winfried, for the introduction, and good afternoon to everyone. I'm really happy to have the chance to give this short presentation today. I'd like to give you a short overview what is going to expect you in the next 10 to 15 minutes. I'll be talking about a topic that affects millions of people worldwide, the complex link between chronic pain and depression, like Winfried said. These two conditions are deeply connected and have a huge impact on people's quality of life. And in the following, I will also sharing two projects from our lab. So the first one, to start with, we will look at how mental health and chronic pain are intertwined at a neurobiological level, focusing on fibromyalgia, as an example of where these two connections are particularly visible. And in the second project, I'll talk about neuropathic pain in older adults. There I will share some new research that we are going to start next year. Mental health problems impact a significant portion of the population, affecting 1 in 6 Europeans, and this amounts to an estimated 600 billion euros per year in economic costs. And these issues are not isolated, but are closely linked with other health conditions, especially chronic pain. The impact of mental health condition extends beyond health, contributing to social disadvantages such as unemployment, poverty, and limited educational opportunities. And also since the onset of the COVID-19 pandemic, these issues have likely intensified and also leading to an expected increase. So for those of you that are maybe not so familiar with chronic pain, just a little general background. So chronic pain is pain that sticks around for a long time, usually lasting between 3 to 6 months or even longer. It's a big and growing problem for public health, affecting roughly 20% of the European population. The impact of chronic pain goes far beyond just the physical discomfort. It often limits people's daily activities and seriously affects their quality of life. Many people with chronic pain also struggle with mental health issues, in particular depression, anxiety, or even substance abuse. This combination of physical and mental health challenges creates a tough cycle that can make it really hard to manage both the pain and mental health aspects at the same time. Depression is now a major global health issue, ranking as the third leading cause of disease burden worldwide. This means that it has a huge impact on people and communities across the globe, showing just how common and disabling it really is. Among all mental health conditions, depression stands out not only because it's so widespread, but also because it causes such a significant disability. It also affects daily lives, productivity, and overall well-being on a massive scale. Like Winfried said, research also shows a strong link between chronic pain and depression. And when someone lives with ongoing unmanaged pain, it can lead to feelings of helplessness and despair, and often triggering symptoms of depression. And clinical studies, they suggest that up to 85% of chronic pain patients also experience severe depression. In this talk, like I said, I'm going to talk you through our study looking at how depression and chronic pain are linked in people with fibromyalgia. We are especially interested in finding out in this study if a mindfulness-based intervention might help to restore the dopamine system in these patients, which could or should improve both the pain and their mood symptoms. And I will also go over some early findings from questionnaires, which gives us a first glimpse of how well this approach might work for these patients. For those of you that are not familiar with fibromyalgia, maybe can you go back one slide? Yes, thank you. Fibromyalgia syndrome is a long-term chronic pain condition that can seriously affect people's lives, as it has many different symptoms, such as widespread chronic pain, sleep disturbances, cognitive impairment, and up until now, we don't yet know what exactly is causing fibromyalgia. It mainly impacts women, and many women with fibromyalgia also experience depression. In a previous study of our lab, we could show on a neurobiological level that that we can distinguish patients with fibromyalgia that have depression and those that don't have depression. And we could also show that depression, or the presence of depression, makes fibromyalgia symptoms worse. And in this particular study here, we were looking at a mindfulness program that has been developed in the United States by Eric Garland, called MORE, short for Mindfulness-Oriented Recovery Enhancement. I will talk about more in a bit, but our hypotheses were that the practice of MORE could help the people with fibromyalgia manage their pain better and also improve their mood symptoms, and in general enhance their quality of life. Just very briefly about the MORE intervention. MORE is an 8-week group program created to support well-being and resilience, and it's especially beneficial for people facing chronic pain, substance abuse, or facing stress related to chronic pain. And there have been quite a lot of studies in the United States that showed that MORE can reduce pain-related issues, can also lessen the sensitivity to pain, decrease cravings for opioids, and also boost positive emotions in people with different types of chronic pain. However, up to this point, there hasn't been a study that has been done entirely in people with fibromyalgia on its own. Just very briefly about the therapeutic components of MORE. It brings 3 main therapeutic practices. So it's mindfulness, savoring, and reappraisal. And those 3 components work together to help people manage their emotions better and also to see life with chronic pain in a more positive outlook. So just very briefly, I guess most of you have heard about mindfulness. In this particular program, it's about helping people to tune into the present moment. So basically in their pain experience, instead of getting caught up in their worries or judgment about their sensations, it's about observing their thoughts, feelings, and body sensations with gentle curiosity, and just noticing without getting pulled in and becoming more self-aware. So basically they learn to step back from their pain or to their reactions to pain, which should be really freeing for them. Then the second component is the savoring, where patients learn to take in a moment to fully immerse themselves in positive experiences, to really enjoy them. So in the program, it's described like pressing pause on a happy or meaningful moment and really embrace it with all its components. And the last component is the reappraisal, which is taken from the cognitive behavioral part. So basically it refers to the process of looking at challenging or negative experiences from a new or more positive perspective. So in a way to reshape our understanding of situations. So instead of just reacting to something difficult like the pain, the reappraisal should help the patients to mindfully reflect on it and see something more positive and foster their resilience and feeling less overwhelmed. So this is a bit about the program. In the next slide, I'm going to show you the outline of the study. So, so far we have enrolled 24 women with fibromyalgia syndrome. They were randomly split into two groups. One received the more treatment, where the other served as a waitlist control group. So we had, up till now, we have 14 participants in the more group and 10 in the control group. And at the start, we collected also PET data with F-DOPA to check the dopamine activity. Then they did also an fMRI and questionnaires about pain, mood, and quality of life. Unfortunately, the PET and the fMRI data is not yet analyzed. So today I'm just talking about the questionnaire data that we have. And we also did some stress markers that we recorded, like cortisol and alpha amylase. And they did the same procedure after the 8-week intervention. There's also follow-up 3 months later. So the preliminary results that that I'm going to show today didn't show any reduction in depressive symptoms or improvement in pain, which was very surprising for us, especially since the previous studies in the States were also positive. But right now, as we are still concluding all the data analysis, it's still too early to draw any firm conclusion. But there might be a chance that either the intervention is not the best for fibromyalgia patients that are often refractory, or which we can also say that our study might be underpowered to find significant differences between the groups. Yeah, so this is unfortunately all that I can say today about this study. And then I'd like to tell you about another project that I'm very excited about. It's called Neuropathic Pain in Older Adults, and it focuses on the common biomarkers related to pain and depression. We're planning to kick off this project next year, and the goal is to dive into the physiological mechanisms and biomarkers that affect pain perception in older adults. And we will also test if a mindfulness-based online intervention, which we developed at the University of Freiburg, can have an impact on some of these biomarkers as well. Chronic pain in older adults is actually quite common, but it's often not talked about, so it often goes unnoticed. Many seniors may avoid bringing it up, either because they don't want to feel like a burden, or they think the pain just comes with getting older. However, when pain is left untreated, it can have serious effects. So in older people, it can often show up along with feelings of depression and can also impact a person's quality of life. This kind of pain can lead to lower activity levels and make people afraid to move, reduce their independence, and cause social isolation and sleeping problems. So basically, these effects take a toll on both the physical and mental health of older people. Treating chronic pain in older adults can be quite tricky because it changes also because with old age, they have different metabolisms, so medications don't work the same way. And also psychotherapeutic treatments, there's a lot of stigma associated with it. So I see that quite a lot also in the practice where I work. So our idea was to create an online program that we did. Basically, we created an online program designed just for older adults dealing with chronic pain and their mental health issues. And the program is not just focusing on pain, it also addresses the comorbidities, it addresses also aging aspects. So it's really a program that we created to respond to the problems that older adults with chronic pain might face. It's also an 8-week online course called EMMA, which stands for the Short Ecological Monitoring and Management app. We published it in 2021, the protocol, and the program combines several approaches like cognitive behavioral therapy, mindfulness, and positive psychology, with the common goal of helping older adults to better manage their pain. So far, we have tested it or we piloted it in a very small group of 10 older adults at the University of Freiburg. And the early results, they suggest that it might help to improve the pain levels, mood, and quality of life. However, we need to test it on a larger group to confirm these findings. So basically, the study that we're planning for next year is a little bit more so the project focuses on 2 main goals. The first is to explore how pain is experienced and managed by older adults who live with chronic neuropathic pain. So basically the aim is really to look at the psychological and biological factors. To do this, we will use the Chepstow mode and EEG recordings. At the same time, we'll also collect blood to determine some biomarkers like BDNF, saliva sample for cortisol and alpha amylase, and also doing some ambulatory assessments to really see what psychological factors impact, to also better understand chronic pain in older adults, or in this case, chronic neuropathic pain in older adults. Then they will also be randomly assigned to the intervention or to a waitlist control. And after the 8-week intervention or the waiting time, they will do the same procedure again, and we will see if the biomarkers change, if the also the experimental pain there paradigm, if there was some changes. Yes, this is about the upcoming study. Yes, I think with this slide, I've come to the end of my presentation. To wrap things up, I want to highlight the important takeaway that depression and chronic pain are often found side by side, and they share an intertwined relationship that goes beyond the physical. So it can be quite tricky to diagnose, and often it goes also unnoticed because there's this huge overlap. So when depression and pain aren't addressed, they feed into each other, creating a vicious cycle that can seriously affect someone's quality of life and ability to recover. However, by understanding how these conditions reinforce one another, we can create a much stronger and more comprehensive approach to care. So thank you all for your time and your attention today, and I'm excited to answer any questions you might have. Thank you very much.
Thank you so much, Katharina. That all sounds really interesting. And I will stop the sharing of your slides now. And maybe we will listen Patrice first, and then we will have still some time for the questions. And here are your slides. Hopefully everyone can see it. Okay, perfect.
Thank you. Yeah. Thanks for the opportunity, and I think that that will be very complementary to what we have learned. So it might be interesting for clinicians, researchers, but also non-clinician, non-scientists, and including even patients or people knowing, people living with pain. That might be interesting to discuss how to inform research projects and how research can inform the other stakeholders, including our decision makers. So that's why we have started this big advocacy project at EFIC, but EFIC wouldn't be very far without patients. So we can go to the next slide. And I have already introduced myself, and that's not the most important slide, so let's continue. Super, and this is an important one. So in particular, Without Pain Alliance Europe, PAE, represented by Elisa Gitila. Then we have initiated SIP, so the Social Impact of Pain platform, which is really a platform then where patient organizations and Pain Alliance Europe represents, so it's an umbrella organization representing 400,000 people living with pain, and professionals represented by me and for EFIC can interact and then raise awareness on pain. A very important person is Angela Cano Palomares, who's on the slide, and helped by fantastic trainees like Marta. And Angela is the engine of all these things, and doing a lot of work to contact and to bring people around the table. That can be decision makers, but again, stakeholders, like people from different nations in Europe, but also from different backgrounds. Next slide, please. So what does this multi-stakeholder platform does? The aim being raising awareness, that's quite clear, but then collaborating with different stakeholders named here, professionals, patient advocacy group, but even much more, because we can always enrich perspectives like during webinars, like the today's one. To be transparent, that's important. We're supported by Greenendahl and GSK. Next slide, please. So all we know that pain affects a lot of people, and for some, it severely affects them in terms of quality of life. And we know that chronic pain and mental health frequently co-occur, but even more than that, they can aggravate each other. That's what we have discussed. The complex interactions mean that complex solutions they have to be considered. And that's why, of course, biopsychosocial approach has been the preferred one, because if looking just at biological aspect, it may not be enough. It's a complex equation with different determinants, and that's what we have heard from research projects as well. But that's what we want to cascade, and to be sure that people are adequately informed when taking decisions about how to manage pain, how to manage mental health care, and how to support that appropriately to develop it in a right way. Next slide, please. Very concretely, what SIP did in 23-24, important milestones were the joint statement on pain and mental health with 10 partner organizations. So that was very important to enrich the perspective again, to be sure that we were covering what we should cover and that it was really patient-centered, and more than patient-centered, also centered on people living with pain, some not wishing to identify themselves as patients necessarily, others identifying themselves as patients because needing the support of the healthcare, needing a better support and a better response from the healthcare system, including just access to care, which is important as we know that it's still heterogeneous. We hosted an event at the EU Parliament that was attended. We got the support of member of the EU Parliament, and that was very important and to get that on top of the agenda of the EU Commission and the Parliament as well. And very concretely, that does mean something. That does mean that we have been successful in terms of amending documents being the foundation of the legislation and the regulations in Europe, including what's named here, the European Parliament Mental Health Report. An example of that is when we have heard from Winfried with the very important ICD-11 classification that has been developed with a very rich chapter on pain. That's really a game changer, and that's now integrated in the regulation of the European health data space. So all the countries in Europe have to use the last ICD-11 classification, including this chapter on pain, which is potentially an enormous success and impactful in terms of data interoperability, but also just in terms of recognition of the problems. That was not the only amendment. Other amendment included the intersection of pain and mental health, workplace adaptation, holistic care, awareness campaigns, and early diagnosis and early experience. And all these aspects are important because members of the EU Parliament are very sensitive to this kind of aspect. They need to be informed, and together we, of course, make stronger. Next slide, please. We have developed a leaflet, organized a not yet delivered workshop in Lyon. We have heard about the Congress in Lyon to save the date until tomorrow. That's still the early bird registration rate. And we monitoring the EU policy on pain and mental health and continuing to be sure that everything is done to optimally inform the different stakeholders and decision maker. Next slide, please. That includes also getting back to the scientific community and then informed by things that you know as patients or patient partners or patient representative or clinicians, hearing and learning from patients. Then we have to cascade the scientific community to let them know what we have found or how the interaction was enriching the perspectives of all of us. So that's the example of this letter to the editor that we have published recently about pain and mental health comorbidity, and this is a very, very short summary of the kind of information that you can find in that letter, and remember that readers of these scientific journals can learn about prevalence of pain, even if it's not primarily a journal about pain, the problem of COVID, access to care, created and the current challenges, and finally our recommendations. So that's also in the next slides. Something that we have done recently in what was called in the past a blue letter. It's now called Rapid Response in the British Medical Journal, and the title is self-speaking. That was about access to care to people living in the street and suffering from all the problems related to drug use and also prisoners. So very particular population, but with a complicated life, suffering from a lot of stigma, but needing a lot of support, much more than what we currently offer, and then that participated to a debate in one of the top journal in terms of scientific impact. So that's again where we have described the context challenges and our social impact of pain platform recommendations. Next slide, please. Yeah, so that was all. I do hope that it well a link between what has been developed, described by Wilfried Reeve, and also the importance of research projects and then to cascade research findings to stakeholders and to decision makers, but also getting back to researchers to close the loop and to let them, or to get a patient voice on top of the agenda of what all we have to consider when designing new projects. Thank you very much indeed.
Thank you so much, Patrice. Okay, so I stopped sharing my screen, and now I think we will have a couple of minutes for questions. So I will read them. There is a question for Katarina. Did you make power calculations before the start of the study?
I guess you're referring to the first one.
Yeah, I think so.
Yeah.
Yes.
Yes, we did. And yeah, basically due to the COVID restrictions, as we have some more patients that need to be analyzed. However, for this talk, there was not enough time to do all the complete sample. So, and I'm not allowed to share more than these that have been analyzed. So, yes, we did. And I think they needed to be around, if I'm not mistaken, 60 participants or something. So the final sample that we got is a little smaller, but better than what I shared today.
Thank you. There was also a question about the fibrodopa study. So are you still recruiting participants with fibromyalgia? And if so, is recruitment limited to Germany? This is one question, and there was a second part, but I think it's enough for start.
Yeah. No, so we finished actually. The data collection is finished. However, we might continue doing other studies with fibromyalgia. So if someone has some patients, we are always very happy to receive. It depends where or what language they speak. So what we included were German and French speaking participants. So it depends if, but we had also patients from Germany in another fibromyalgia study that we did. So this shouldn't be a problem.
I think you kind of answered the second part of this question. So if the results are positive, do you plan to expand the study to other countries or include a larger participant group? And I think that was already your question to that. Thank you. There is another one. So Patrice, can I ask your opinion on the recognition of other than anxiety and differential mental health condition in people with chronic pain?
Definitely, very interesting questions and important one, because much has been done, but much is still to be done. So that's the short answer. Let's think about, just to mention a few, but I'm certain that there are others and other ideas that are very important to consider here in terms of interference of mental health condition on the social level. Let's think about also the problem of our aging population and dementia, pre-dementia, delirium, and pain. Let's think about all the conditions related to sleep disorders, fatigue, even independently on depression can have an impact on mental health, risk of suicide. I have briefly mentioned substance use disorder, which is also another kind of entity also interacting with mental health disorder, depression, anxiety, and others. It's not exclusive. So there are many different situations that can all co-occur, but also aggravate pain. And much has been done in terms of thinking about that. the existence of the development of the biopsychosocial model to manage pain from in the last 4 decades. Consider that at the societal level, much is still to be done, because I agree that formally, when we look at the regulations and the legislation, how is it done to better support these people? It's not well done. Integrated care is not yet a reality in the majority of our environment. Coordinated support is not yet a reality, so we have to continue to raise awareness on that, because the relevance is quite clear. The concrete implementation of support is not yet there. So I do hope that it answers the question.
Thank you. I have actually a question to Winfried about how to, it's my question to tell the truth, but I think pain in clinical psychology, or even just in general psychology, it's really underrepresented. So, and now we can see that it would be important to have more pain researchers in the field of mental health as well, or clinical psychologists. How do you see, how can we raise the awareness?
Well, this is a difficult question, but I can follow up on what Patrice has said, that if we consider the clinical syndromes that are summarized in DSM-5, for instance, nearly all of them have some pain symptoms as criteria. In depression, you have abdominal pain or back pain, and in panic disorder, you have chest pain. So there are always pain symptoms that go along with the mental disorder conditions. Even in conditions like anorexia, if you are able to motivate the patient to increase the food intake, the next symptom the patient will suffer is abdominal pain, because all the guts have to restart working and so on. So we are really confronted with pain symptoms all over the field of mental disorders. Yes, I agree. We have to improve our trainings. We have to consider pain symptoms more prominently than we do so far. And we also have to fight a little bit against a stereotype. And people who work in mental disorders, they often see pain symptoms as a kind of peripheral symptom, and not as a disorder of its own. Sometimes it happens also vice versa. Or in some years ago, I was working with a very experienced colleague on sleeping disorders, and I said, "Oh, sleeping disorder is just a epiphenomenon of depression." And she said, "Are you crazy? Sleeping disorders are disorders by their own." And I think it's the same with depression. So what we have to, and pain, what we have to fight against is the stereotype that one is just a peripheral symptom of the other, but we have to emphasize the more correct view, in my opinion at least, that these are clinical conditions that are relevant by their own, and there is a lot of experience about them. We have a huge pain field and a lot of pain results, like Katarina wants, that are of relevance for the people who are working in mental disorders, and maybe also a little bit vice versa. We shouldn't consider depression just as a result of the chronic pain condition. If depression is established as a clinical condition, it has its own dynamic and needs its own treatment. So I think the major point is to fight against this stereotype that one of these syndromes is just a result of the other. So to avoid any causalities, but to consider these conditions as something that has a right on its own.
Thank you. Thank you so much. And I think we are kind of done with the questions. I haven't seen any coming. So thank you so much for the participation from everyone, and thank you for the wonderful presentations, the time that you gave to us today. So hopefully meeting you in the congresses mentioned before. I wish you a very nice day. Thank you. Bye.
Thank you.
Thank you very much.